Grazie. E grazie a tutti gli organizzatori e alle famiglie GNAO1 che ci hanno dato questa opportunità. Oggi sono
Thank you very much for having me here. I heard many interesting insights today, and this is very important to go on with our work and continue with our research. So, when we talk about the neuromotor department, what is the situation? What are the tools that we have available that we can use? What are the goals that we want to achieve when it comes to children with GNAO1 mutation? What are the goals again? And Dr. Amantis already said that we really need an integration of the work of different people that take care and interact with our children. So, from the many times today we heard that we don't have much literature available on this disease, so knowledge about it is incomplete, and there isn't much on this disease in academic publications. And so what we can find, though, is what has been done in similar cases, for instance, in cases of cerebral palsy. The most common approach is the rehabilitation approach that fosters the creation of new skills, compensatory approach that works on the environment, and the approach that is focused on the recovery of disability in the framework of support to the development of the subject. I think we can combine the three approaches because none of them alone is complete. So I think that a combination of the three of them, it's the ideal path to follow. Guidelines explain how it's important to work on the function and not on the deficit. So the focus of our intervention must be on the development of abilities and participation. There are few studies in the physiotherapy and occupational therapy on the hyperkinetic disorder. Reviews have more to do with cerebral palsy than what we have in GNAO1 children. So, of course, the approach can be based on these models, on the clinical experience, and we can think of neuromotor intervention in a more integrated way, as I was saying. So the creation of goals must be focused on what is the starting stage of the child, what kind of skills he has developed, what skills have not developed. So on the points of weakness and points of strength that had been mentioned before. So I'll make a reference to the study of Professor Lean that tried to codify this intervention that was created in 2004 for children with movement disorder that has been experimented on children in between 6 and 21 years of age. We're talking about hyperkinetic children. The approach is a problem-solving approach, which means that they identify specific goals and they work on the emergence of skills that are necessary to reach the objective, the goal, the identification of strategies, the generalization, and transfer to the daily life. So nothing too different from what we are doing. And this is done in specific sessions. This is a codified work, so we have results, measurements. There are some limitations for us right now because not only the age range is different, but also the prerequisite must be good cognitive skills, good verbal comprehension, and children that must be quite independent. Unfortunately, not all of our children have these prerequisites, but the kind of approach can be shared, can be adapted to, and can be experimented also on other kind of children with different needs. However, the kind of approach is definitely good for us too. So let's go back to our children. I will not talk about the clinical picture because we've been hearing about movement disorders. So we heard about chorea, the lack of good posture, hyperkinesia and hypokinesia, epileptic crisis, and this perceptive crisis too. I will talk about this perception. It's a deficit in collecting information, collecting data, and this perception can be both a quantitative level, so we can have individuals that are highly sensitive, or it can be qualitative. It means how much the signal is perceived by children. Some of our children are definitely children with hyperperception. Some indications are the startle reaction that we saw in very young and small children, a strong difficulty in modulating information, incoming information. And sometimes we've seen in some cases that this can be a trigger of dyskinetic attacks. And talking with Professor Leuzzi was mentioning the case of the mouse with hyperalgesia. So in that case, there is also an alteration of the incoming signal. Of course, we cannot compare the two things, but still gives some indication. So what are the symptoms and signals of this perception alteration? The presence of the startle reaction, the avoiding reactions, the lack of contact, the difficulty maintaining a posture, intolerance to vertical sight, and so on and so forth. All of this can negatively affect global movement. And another data that we need to take into consideration, you parents definitely know this, is the importance of the emotional state of the child, how sensitive the child is, and how he or she reacts to what happens in the environment around him or around her. How do we define intervention goals? It's definitely important to make a previous assessment which defines points of strength and points of weakness so that we can identify the most urgent needs. So direct observation is one important rule, and other important tools are the use of scales and protocols. Those are important because they are an important reference, and second, they are necessary to control over time if therapies work or not. For instance, we heard about this about deep brain stimulation or again drug therapies. In the presentation of Professor Coy, there was the gross motor function classification system and the manual abilities classification system. These are not scales. This is an observation tool where we can observe how the child reacts, how many difficulties or how easy or difficult it is for him or her to use his hands, for instance, to be able to move into space, to keep a posture, or again the capacity to grasp objects, to maintain objects, or the lack thereof. And all of this is divided into different categories and different severity levels, and they can be used over time to compare results of rehabilitation procedures, for instance. There are some very specific scales. They are limited, meaning that they are dedicated to one single symptom, so we don't have that integration that we've been talking about so far. For instance, there is the first one, it's on dystonia, the second is on dyskinesia, And the third scale, it's an attempt to see the disorder movement globally and also to analyze and measure the qualitative aspect of the disease. Other tools that are very important is all the information that we can gather from parents, both clinically and how information that they gather observing their children, and then also observation of their life environment, which means to observe how children behave at home, but not only, also in school. So, as we said, there are not specific and dedicated scales. So we hope there will be some in the future. There are some other points that I believe are important to stress when it comes to qualitative aspects. So scales are important, but if we need to observe the quality of life of the child and how he uses the resources he has and what are his strategies, what's his movement repertoire, what are the aspects, the individual aspects. Let's talk about rhythm. Let's talk about time schedules. How quickly or how slowly a child, how long it takes him to understand what kind of movement he has to make to grasp an object, for instance. We need to be respectful of that timing, because that's the only way to support our children so that he can learn the process, he can stabilize it, he can repeat it, and he can learn it. So if just verbally we tell the child, I'll wait for you, you have all the time in the world, that will already be a very positive signal for the child. Some important aspects are the promotion of initiatives, so to support entertainment, to support sharing, support the potential of the child. The creation, and I will repeat what Dr. Manti said, but I think we can all agree about these features. So the creation and adjustment of the environment according to the needs of the child, and the contribution of the adult individual meant as a space, safety, and sharing, which means that the parent doesn't have to substitute the child, doesn't have to do everything in his or her place. Also, we can talk about three main groups of intervention: postural, gestures, and cognitive communicative department. But again, I believe that the ideal intervention must be focused on the child, on the patient, and on the family. It must be an integrated one. So it can be also an intervention that is not direct, that doesn't need the use of our hands. But thanks to identification, to verbally explain some proposals, then again, all of this must be applied to every single patient, every single family. When it comes to postural approach, of course, it's important to identify some of these aspects. We see how it can be difficult for children to maintain a certain posture, and these has as an objective also to contain hyperkinesia. So today, listening to what my colleagues had to say, I was very doubtful about postures that we sometimes think are wrong and we correct. So there was a child on a pram, and she had her head tilted, and then the parents turned on a video to make her watch it, and she was moving her head for about 10 minutes so that she would try and find the right posture to see the video in front of her. So again, I need time to observe the child and understand what is the best posture for her in this case. So, as far as these perceptive aspects are concerned, it's important to identify situations that can be problematic. Some situations were talked about this morning, like fevers, infections, sore throat. This can all be triggers, but also the emotional state is important, and the environment is extremely important. Some situations might be normal to us, but for the child, it can be a stimulus that is over their threshold, something that they do not tolerate. A blinding light, too many people, too many objects at once, other people's expectations. All of these factors must be identified and taken into account. How can we do this? We can do this through simplification, streamlining of the environment. We might simplify, we might reduce the number of objects, for instance, anticipate events, create indexes that allow us to anticipate what is about to happen. Training is definitely important.
Del vuoto, a quei bambini per esempio.
Think about the fear of void. Think of those children that even if they're laying down, they are afraid of falling. So training on that can be very, very useful to reduce that fear. So it's something that trains children to gradually tolerate and become familiar with that kind of feeling. And again, ideal solutions must be found because I can create the best room for the child at home, but if at school the situation is not comfortable for the child, then there is a discrepancy that the child cannot tolerate. Clearly, when it comes to posture, auxiliary equipment is extremely important. We see one of our children, she started very young, but here she could not control any of her movements. Then she started to manipulate objects in a more contained environment. As she was growing up, we proposed other equipments that now she uses fine. She can control the movement of her head in a good way now. Of course, the parents are always present when she's sitting on the special chair. I decided not to show her face, but I can assure you she was really smiley and calm. She's working on verticalization now, and she has the intention and will to move, so we'll try in a few weeks or months try to make her walk with, of course, auxiliary equipment. This is just an example because for some children, even the chair might be too difficult. So again, identifying the specific situation of the child is important when it comes to proposing solutions. Of course, there are some criteria that we need to follow when we need to choose auxiliary items. It must be practical. It must be used in the house. It's useless to find the best chair available if cannot be used in the house. It cannot be brought to school, and it must be accepted by the parents and the family. So working on these aspects has very positive outcomes on development, definitely on attention and participation. Think how important it is to support the visual exploration of the surrounding environment or the communication tasks, for instance. Also a push towards independency. It's important. For instance, the child starts feeling an individual that is something different from the mother and father. If he can keep a posture, it doesn't have to be hold all the time. We talked about communications, and we said how good posture can support the exploration and activities with the objects. With these children, it's difficult to control postural tasks and gestures at the same time. So we need to eliminate one of the two difficulties. The system controls posture, and the child can actually activate movements and muscles. And last but not least, a good posture is a good support for our body function. For instance, when it comes to feeding, to keep a good posture is good also for feeding. I really want to stress how gestures and the rehabilitation of gestures must be integrated with drug therapy. So when drugs and medicines reduce hyperkinesia, then the child can start using movement modules that are more specific. So the first thing to do is to work on simple things like grasping, control, the maintaining of grasping. And according to how it evolves, then choosing more specific schemes. Here we need many environmental facilitations. We'll take a look at them. And let's go back to posture. There are many ways, there are many tools that can be used. This was the first prerequisite. The second one is to create facilitations in terms of surfaces where you work on. It happened to me that proposing some ideas, some other ideas came up, but more creative, more fit for the child. So, for instance, to create a surface that has a limit around, that has a border, so that it's a limited space that the child can operate on. To work on systems that actually make the objects more firm. This is useful for their daily activities. For instance, to use a dish that has a suction cup underneath, so that when the child grasps the food from the plate doesn't move. And these needs to be applied to playing in games too. If we want the child to be amused, to be entertained, then the toys that we propose must be adapted to the child. There are so many different materials that can be used, stickers, tubes. So let's try to understand what are the objects that are of interest for the child, and then let's modify the object so that it can be grabbed, it can be used. Last point, integration with other intervention. Again, as I was saying before, if we use medicines and drugs, we also need other approaches. This can also provide clinicians and doctors with more data to understand how effective the drug therapy is. And this can offer information to many other actors involved in the process. For instance, the ones who are in charge of communication, or the educators in schools, or so this brings us back that all of our approaches, AAC, to what we propose during therapy, something that the child starts experimenting during therapy, but they have to take it home. It has to be applied to their daily lives. And this is why it's important that the communication and collaboration network includes all the actors and all the people that are involved in the child's life. In time, our intervention must be dynamic, must be flexible, because it has to evolve together with the child. So our proposals must be adapted to the new situation the child is in. We always have to consider these variables, considering that some of them might work, some of them might not. After the stonic attack, the stonic crisis, some of these abilities can be reduced or can be lost, so we have to restart there. Two important take-home messages. It's important to verify how effective all of this is with very specific tools, and not only skills, but also protocols and sharing. Because if we share, we can also share approaches. And the other aspect that I think it's very important is the sharing with the family. Not a sharing in terms of I just tell you what happens, but really understanding what the needs are to propose a goal, to listen to the parent. Thank you very much for your attention, and I would like to thank my two colleagues of Villa Dante Center that helped me in this with this presentation. Thank you.